Good evening, everyone. I'm Dr. Sara Mustafa from DentistChannel.Online. Welcome to today's webinar about patient complaints in removable prosthodontics, how to diagnose and manage. While we are waiting for the participants to join the session, I will introduce you to our company. DentistChannel.Online is a digital dental media company. It is your marketing solution for dental events, product launches, workshops, and courses. We also provide a collection of scientific articles and blogs about different topics in dentistry. We work hard to be your first-hand information on the technological advancements in the dental field. Now it's time to start the session about patient complaints in removable prosthodontics. If you have any question about this topic, please feel free to ask it in the question and answer box, and we will answer each and every question at the end of the session. I will start by introducing today's session speaker, Dr. Mahmoud Ramadan. Dr. Mahmoud Ramadan has completed his graduation BDS from the Faculty of Oral and Maxillofacial Surgery in MUST and post-graduation in prosthodontics from the Faculty of Dentistry at Mansoura University. He has a PhD in prosthodontics from the Faculty of Dentistry at Al-Azhar University of Cairo. He is also a visiting professor of removable prosthodontics. Welcome, Dr. Mahmoud. It's our pleasure to have you with us.
Welcome, Dr. Sar. Thanks for this another opportunity to meet my friends all over the world. And I wish that we have a very interesting lecture today.
I hope so. You can start your session.
Okay, Doctor. Hello, everybody. We are talking today about patient complaints that everybody face in our clinic, how to diagnose and manage. This is what does the patient feel about the dentist. Every patient are fearing his dentist, but here we are replacing the rules. Here, the dentist will be under the desk and the patient will be in front of the desk because the dentist here is the one who is afraid from his patient complaint. Here we divide the complaint into 3 points. First, we must diagnose the cause of the complaint. Well, then we search about its cause. Then we do the proper treatment for this complaint in order to improve our patient quality of life. Here, our aim is not to make a good aesthetic prosthesis, but also we need to do it biological for the tissue. We need also to restore the patient function. So if the patient is not happy about your work, you fail in your work. The causes will be divided to patient dissatisfaction. It may be due to the denture limitations or due to improper selection of your patient. The denture limitation must be discussed briefly for the patient before starting your denture making or your prosthodontic work. He must know that the denture is not be like his normal teeth, previous normal teeth. It will have limitations in mastication, limitation in phonetics, but we can give him a good aesthetics, but not as the God made. We can't create what the God creates. The types of patient according to the house classification, as we know, you may have a philosophical patient, hysterical, indifferent, exacting patient. We should avoid to have the indifferent patient and the exacting patient in our work. Then we will summarize the problems that face us in denture in patient complaint. we have a complaint for the new denture and the complaints for the old denture. When we talk about the complaints of new denture, we can summarize it in this statement. If the denture with clattered teeth bite, it causes pain and nausea. This statement we educate for our students to not to forget any of these causes. If here for irritation and fat, here for taste, speech, statics, and eating the problems of denture. Clattering, it means that the teeth hit each others and they make a noise during speak. Cheek biting, lip biting, and tongue biting. Then pain during wearing and nausea. And the complaint of the old denture, like loose fit, overextension, and overclosure. We start with the first complaint, and the most common complaint that the patient complain from is pain. Here, we divide our complaint into 3 parts according to the parts of our denture. The complaint may come from the borders, the denture borders, maybe come from the denture base, and maybe come from teeth. The borders here, as we see, may be increased or decreased in length, or also the increase in width. Denture base also may have the problem. We may have xerostomia, we may have allergy, we may have oral hygiene problem from our patients. The problem may came from teeth like occlusion, and we will discuss every term like this. Border, like we say before, overextension, basal seat from denture, as we said, or from the alveolar ridge. The problem may be in the denture that the lab made, or from the alveolar ridge of the patient. From the alveolar ridge, the patient may have undercut that you may not relieve well in your denture, or you engage the undercut without using a flexible denture-based material or a soft lining material. So it causes trauma during insertion and removal. The patient may have also a remaining root that you can't discover during diagnosis and the mouth preparation. You must make radiographs, at least a panoramic X-ray for your patient before you starting or progressing into the impressions. Because if you see a remaining root, you must surgically remove it before you starting the impression, your impression and your work. It may lacerate the soft tissue after the denture making and making a pain under the denture base. The causes of denture that may come, poor fit, roughness in the fitting surface of the denture. It may cause irritation and the pain for the patient. Pressure on the mental foramina. It causes pain, localized or referred to another areas. Allergy from polymethyl methacrylate, it's very common. We see an allergy from polymethyl methacrylate and from metallic dentures also. Differential diagnosis, here we see a red patch that resembles to the shape of the denture. Exactly, the shape of the denture is very red and swollen mucosa under the denture base. And we can diagnose it also with patch test. We may have pressure area localized or generalized due to improper impression, improper cast, or due to ravage of the denture base if it is not cured well or if it is not finished or polished well in the lab. Then the problems from occlusion, as we see here, vertical dimension of occlusion, if it is high or low vertical dimension. If it is high, the complaint will be very fast. The patient will complain from pain because the patient can the teeth touch the denture in function in every time, because there is no sufficient inter-arch distance between the teeth. So the patient close his teeth all the time, and this will cause a generalized inflammation of the mucosa under the denture base. Decrease the vertical dimension of occlusion also cause neurological pain and pain in muscles and the TMJ, but after sometimes not immediately as the high vertical dimension of occlusion. Also, there will be problems if the centric occlusion will not coincide with the centric relation. Also, uneven pressure if it is here. White sore area on the side we find on the mucosa due to pressure. Cuspal interference also is a main complaint. If the lab set the artificial teeth outside of the ridge crest or away from the ridge crest, it will if the upper buccal sulcus of the working side, and it will cause a trauma also in tuberosity of the opposite side. Soreness of the sulcus also may be happen due to overextended denture flanges, rough or sharp borders, occlusal interference in eccentric, lateral, and protrusive movements, non-rigid connections between the saddles in case of metallic dentures, inaccurate cast peripheries, and also in teeth out of the ridge crest, as we said before. Soreness under the denture base may be classified into generalized soreness and localized soreness. The causes of the generalized soreness is excessive soft tissue displacement during impression making or jaw relation. You must not make a heavy pressure during registration of the mucosa. We said that to our students and to our colleagues that you must not every time use a heavy or a putty material to register your tissues, because you will subject these soft tissues and bone to a heavy pressure during the denture rest or the rest position. The bone and the mucosa must only subject to this pressure during function only. Also, high vertical dimension of occlusion will subject the bone and the mucoperiosteum and the soft tissue to a heavy forces. Lack of harmony between centric occlusion and centric relations. This will cause a deflective occlusal contact that may cause anterior-posterior displacement of the denture during function, and this will cause a generalized soreness under the denture base. Lack of contact in the balancing side is also incomplete denture cases, of course, will cause a generalized soreness. Allergic reaction, as we said, to polymethyl bisacrylate or the metallic content of denture. Unfavorable denture bearing tissue. If you make an impressions and start working for an abused denture foundation, you will face a generalized soreness under your denture base. Poor oral hygiene. If the patient can't maintain his oral hygiene measures for tissue care and denture care, he may face a generalized soreness under his denture base. Also, bruxism. If the patient have nocturnal habits like bruxism or clenching, whatever, it will cause a generalized, because we have a high duration of force and a high magnitude of force falling onto into the mucosa and the bone of his denture foundation. So In this patient, if it will not treat it properly, we may face a rapid bone resorption, and the denture may need a frequent relining soon. Xerostomia is also a great problem because the saliva acts as a lubricant under the denture base. If there is not sufficient saliva in quantity and the quality, so the patient may complain from a dry fraction between the denture base and the mucosa, and this will cause a generalized inflammation and also causes a lot of, the patient is more subjected to candidal infection and difficulty in deglutition and many problems like poor retention also, because the saliva is also important for the physical means of retention to obtain the film of fluid required to obtain the a proper physical retention. Okay, the last one here, wearing the denture at night. As we said before, the patient must be instructed to wear the denture only during the day, and not to wear it during night. He must have a period of rest, as we said, about from 8 to 10 hours daily, in order to give the mucoperiosteum the chance for the blood circulation to go to the mucoperiosteum and decrease the amount of bone resorption for our patients. Okay, we are going for localized soreness, and the causes of localized soreness are occlusal prematurity in centric and eccentric. Number 2, insufficient relief of bony prominence. Localized pressure from denture base also caused a localized soreness. And finally, irregularities on tissue surface of the denture. Here, we also divided the types of localized tissue irritation according to the denture part that cause the irritation: border, basal seat, and the teeth. And also according to the part in the anatomical landmarks in our patient mouth: crest, vestibule, anterior lingual and lateral buccal slope, median palatine raphe, retromylohyoid area, and tuberosity, as we see. Okay, the border will cause only irritation for vestibule, as we see here. Overextension can cause an irritation. We can diagnose it by displacing wax over the overextended border. If the wax displaced completely from the border, this means that we have an overextension. Okay. Take into consideration that the patient may have an abscess ulcer in the vestibule. So you must differentiate between the traumatic ulcer and the abscess ulcer, not to misdiagnose the condition. Also, the border we may have a complaint in the retromylohyoid area from the overextension that may left overextension of the labial flange that may left the denture posteriorly. We may also have a problem in tuberosity area from the overextension of the posterior buccal flange. Then we will talk about the basal seat here at the ridge crest. We may have bony spicules, and remaining roots. As we said before, we must make a proper clinical and radiographic examination to see what under the mucosa. Then anterior lingual and lateral buccal slope. We may have a pressure here in this area from the basal seat. Also, lack of relief of median palatine raphe will lead to denture rocking and will lead to irritation also of the ridge slopes. This in the first, after that, we may have a fracture of the denture inside the patient mouth, midline fracture. This is the most common complaint from lacking of relief of median palatine raphe. So in this case, the patient should have relining or rebasing of his denture. Retromylohyoid also may have pressure in the retromylohyoid area from the basal seat. Tuberosity may be unilateral or bilateral irritation according to the undercut, if it is bilateral or unilateral. We may have a pressure area, as we see, dimensional changes may occur from the denture base during finishing and polishing or during curing. We may be corrected by relief or rebase. Occlusion also we may have problem from improper occlusion from the artificial teeth. At the crest, we may have an irritation at the crest of the ridge due to deflective occlusal contacts. In the vestibule, we may have a problem from tooth of the ridge. Anteriolingual and buccal anteriolingual and lateral buccal ridge slope, we may have irritation from deflective occlusal contact, and when the centric occlusion is not concurrent with the centric relation, also we may have a problem. In the median palatine raphe, anterior contact in centric relation, we must have a sufficient anterior horizontal overlap. Here we must reset the anterior teeth again or the denture teeth again. Retromylohyoid area also may be affected from occlusion. Occlusal interference on the opposite side may cause denture movement in opposite direction. Okay. In removable partial dentures also, we may have the patient may complain from pain in or around the abutment teeth. The metallic RBD may be not constructed well. We may have improper clasp arm, improper clasp design, as we made a two-supported clasp for a free end saddle clasp, like we using an acre clasp for a free end saddle area. Lack of clasp reciprocation, improper rest and rest seat preparation. This causes slippage of the denture and causing a pain to or impingement to the gingival margin and the attached gingiva around the abutment teeth. Flexible major connector, this flexing causing a very trauma to the abutment teeth and soft tissue also around it. Traumatic occlusion is also a cause in partial denture like complete dentures. Then gingival impingement and lack of stimulation. Lack of stimulation by coverage of the denture base. If it is not metallic, it will alter the taste sensation, as we said after. And also gingival impingement from the denture base if we have a lack of relief under the denture base. Gingival margin and sensitive areas must be relieved when it is covered by the denture base. If the tooth also is out of function for a long time, it must not be used as an abutment. It must be used first in order to program it for the masticatory forces, and then we may use it at an abutment teeth. Okay. We finished the problem of pain, then we will talk about tongue or cheek biting. Cheek biting may be due to loss the muscle tone of the cheek. This occur in the geriatric patients or patient with high age. Low vertical, making a denture with low vertical dimension will lead to entrapment of the buccal mucosa between the upper and lower teeth, and the patient can bite easily on his cheek. End-to-end relationship of buccal cusp, if we made if we made the cusps like this, end-to-end relationship, this will cause the buccal mucosa of the cheeks is easily entrapped and bite between the upper and lower teeth. But you can make a cross-bite relationship or a normal cusp to fossa relationship like this. This will prevent the cheek biting of your patient. Also, the tongue biting could be occur due to improper buccolingual positioning of posterior teeth. If you encroach in your tongue space, the patient can bite your tongue, can bite his tongue. Number two, level of the occlusal plane. Also, if you set the teeth that the posterior occlusal plane is too low, the optimal occlusal plane will be slightly below the maximal convexity of the tongue. If you make it very low, the tongue come over the occlusal surface of the lower posterior teeth, and the patient can bite his tongue easily. Okay, then we will talk about the movement of denture. This is a very common problem the patient complain from. Okay, the loose denture will be due to these three causes: decrease retentive forces, increase displacing forces, decrease support of the tissues. Okay, decrease retentive force may be due to improper seal, improper peripheral seal, or improper post damming that lead to the denture fall. Under extension in depth or in width of the flange. The flange must fill the vestibule in depth and width also in order to maintain the physical means of retention. Contact, if the contact is not of the denture base, if there is no proper fit, or if we made an excessive relief, also we may lose the denture retention. If the patient have xerostomia, as we said before, there is no film of fluid between the denture base and the mucosa, and there is no physical means of retention here. If the patient have a low neuromuscular control or neuromuscular accommodation to his denture, the neuromuscular accommodation is a great ability for the patient to maintain his denture. And this is a gift from the God. The patient can't maintain it, can't gain it may gain it from training after, if we have a new denture for the first time, after training, the muscles may adapt to the new denture and gain this, but we have a gifted patients that can control a very bad dentures with their muscles and seated with their muscles only without being a good dentures. Occlusal plane, also if we have an error in occlusal plane or in occlusion, this may displace the denture and we can lose the retention. Okay, increase the displacing forces from muscles from overextension of the flanges in depth and width. Also, if we have in denture contact, if we have as we said before, a heavy pressure onto the mucosa. As we know, the mucosa have a tissue recoil ability. So We must not pressure on it a lot. In the rest, the denture will recoil, the mucosa will recoil again, and the denture may not be properly seated inside the patient mouth during rest. Occlusion, error in setting the anterior teeth labially. If we setting the anterior teeth too far labially, we are increasing the displacing force. We try to set the anterior teeth vertically as much as possible to decrease the horizontal displacing forces, as we see here, that may displace the denture, especially the upper one. Okay, the last one, decrease support of the tissues, the causes related to it. If we have a flat alveolar ridge and a high flange, will not coincide with that. If we have a prominent bony eminence without relief, it may cause rocking, and this will cause denture movement. Also, the mucosa may have a problem in mucosa. It may be flabby, it may be non-resilient, it may be fibrous, it may be every case here must be managed well. The flabby tissue may be surgically removed, or we use a special impression techniques in managing these cases, like window technique in selective pressure impression technique to manage the case. I prefer the surgical intervention to give a proper denture foundation before we taking our impressions. In removable partial denture, also we have some causes for movement of denture. Faulty occlusion may cause that, light clasping, overextended denture flanges, improper positioning of posterior teeth, also lack of peripheral seal, lack of indirect retainer may also cause a movement of denture base. Okay, difficulties during mastication. Difficulties during mastications also divided due to improper borders, due to unstable denture from improper basal seat, or from occlusion. The most common cause here is occlusion and problems in setting of artificial teeth. The teeth here may be blunt or flat. As we know, the non-anatomical teeth have poor chewing efficiency. We can use the semi-anatomical to gain the both advantage of anatomical and non-anatomical teeth. Vertical dimension also, if it is very high, the elevate muscle here don't work. The patient have not sufficient interarch space to put his foot between the upper and lower teeth. Patient can't open to get the food, so there will be a problem in mastication also. In case of low vertical dimension of occlusion, the patient will complain from improper chewing efficiency due to the maximal biting force, and the maximal chewing ability will be at proper vertical dimension of occlusion. Okay, the patient may complain from eating, he can't eat anything. This is normal if he has a new denture in the first week. After training and education, and after treating any complaint like pain, the patient can't eat on his denture when he has a pain. So you must treat the complaint first, and then train your patient for eating. I said for my patients that you can't eat on your complete denture after you can eat after 2 weeks or 3 weeks. During this period, we gain the accommodation, or the neuromuscular accommodation to your denture. So the eating experience here is very important, and you must instruct your patient to eat a small amount of food and eat on both sides. and avoid the hard and sticky food in the first period of delivery. Can't eat meat. This is due to cuspal interference and unbalanced articulation, or the patient may have flat teeth, as we said before. Dislodged denture during eating. This is, as we said before, the problems of denture movement or denture fit. Borders due to overextension from the denture base, unstable denture, from occlusion, improper tongue space, cuspal interference, unbalanced articulation, and from teeth if we set it from away from the ridge. Difficulties during mastication. Inability to chew if the patient complain from that. He may take too much food at once. The denture teeth may be flat. The patient may have high or low vertical dimension of occlusion. We may have soreness of the denture bearing area, localized or generalized. If the patient complaining from that the food gets under his denture, where that means that we have an unbalanced occlusion that lead to denture displacement, and then the food get under the denture base. We may have occlusal interference in centric or eccentric. We may have light clasping if we have a partial denture. Inaccurate denture base if we have a ravage of denture base, then the food can get easily under the denture base. Ridge resorption. The ridge resorbed after the denture you made your denture, so the food go in this space. Lack of peripheral fats at margin is also a lack of peripheral seal and fat is also a cause. Okay. Food. The patient also complain about food lodgement around the denture. There may be not enough space between the gingival margin the gingival margin and the floor of the mouth. So the proper selection of the type of the major connector here is very important, that you may have sufficient clearance between the anterior border of the major connector and the gingival margin. If you have not, if you haven't this space, please use blade instead of bars. If we have from 3 to 5 millimeters a clearance space, we may use a lingual bar. If you haven't this space, please use lingual blade. Also in maxillary major connector anterior lingual bar, the distance must be from 6 to 8 millimeters from the anterior border of the bar or plate and the gingival margin, or if there is not such space available, please use a plate to cover the cingulum of teeth and to cover the gingival margin, but don't forget to relieve these gingival margins not to be irritized under the denture base. The space between any vertical component like minor connectors and or clasp assembly or whatever, any two vertical components space must have a space not less than 5 millimeters in order to give a self-cleansable area that can be cleaned easily by the tongue and laps and cheeks. Number two, also any rough or unpolished area in acrylic denture base or metallic denture also may cause the food lodgement around the denture, and this cause very annoying. It will be very annoying to your patient that the food stick to your denture, to his denture. Okay. Difficulties during speech. Briefly, we will talk about phonetics in complete denture. First, the denture, we must know the factors that affect the phonetics of complete denture. First, the denture base thickness, it will be an optimal thickness. Increase the thickness of the denture parts, like palatal plate or like lingual bar, like lingual flanges, will encroach on the tongue space that is required in pronunciation of letters that the tongue the tongue here need a space to pronounce these letters. Also, the denture extension. If we have an overextension or an under extension, the patient can't speak well. Overextension and under extension may lead to denture displacement, and the patient can't speak well with a loose denture that fall every time he speaks. Contouring also of the polished surface is very important. The contouring of the labial flange of the complete denture must be thin, not like the buccal, and the contoured it will be convex in shape to counteract the action of the orbicularis oris muscle. But the buccal flange may be slightly concave to counteract the action of the vaccinator muscle. And this will be not only a biomechanical advantage, but also to give freedom of muscle movement during speech. Denture occlusion is also a factor. If we have a high vertical dimension of occlusion, we have not sufficient interarch space. The patient here lisping during speech, but if we have a low vertical dimension of occlusion, we have an excessive interarch space, and the patient may whistle during speech. We may have whistling. This arrangement is also important. Buccolingual positioning of posterior teeth is also important. We here prefer to put or to set the teeth in the neutral zone, the area that we have a balance from muscles of the tongue inside and the muscles of lips and the cheeks outside. Encroaching of the tongue space here is also a very common problem. Some of our laboratory technicians set the posterior teeth slightly lingual to have a biomechanical advantage, but this is very important, very common mistake that they made because this will cause an encroaching on tongue space, and this must be identified in stage. We must identify that before denture delivery. Also, labiolingual positioning of anterior teeth is also very important in aesthetics, phonetics, and the biomechanics. Arch relationship, if we have a class 2 relationship, skeletal class 2 or skeletal class 3 relationship, this means that we have a small arch and there is a large arch, and will be this will lead to a horizontal overjet, a huge horizontal overjet, and an area of air escape that may not adjust our patient phonetics. Okay, so how to manage these difficulties? Encroachment on tongue space, we may have posterior teeth placed too far lingually. Increase the buccolingual watts of posterior teeth. We must decrease it. In occlusal parameters, we must decrease the occlusal table in complete denture in width and in length also, in order to decrease the force falling per unit area on the crest of the ridge. Excessive thickness of the lingual flange encroach also onto the tongue space. Poor denture retention, as we said before, and how to manage. the patient can't speak well, if his denture fall from time to time. Excessive salivation is also a problem. This is normal when the denture is inserted first, but because the patient body is act as your denture is a foreign body inside the patient mouth. But after accommodation, it will the salivary secretion will decrease to the normal. If the patient have excessive salivation, he can't speak well. Improper lingual positioning of anterior teeth. We must identify it during the try-in. The sound is very important. If we have excessive horizontal overlap, the patient, or excessive air here, the patient can't pronounce the letter S. But he said it as sheen or sha. Aesthetics is also important. We may increase the vertical overlap here for a static reason. Stability and the biomechanics is a factor here affecting the proper labiolingual positioning of anterior teeth. We can increase or decrease the horizontal overjet according to the phonetics and statics and stability also. Okay, we are talking now about gagging or nausea. Causes of nausea: improper adaptation of major connector to hard palate, overextension of major connector on palatal tissues, increase the thickness of the palatal connector may also cause a gag, a low vertical dimension of occlusion, crowding of tongue and the palate, high vertical dimension of occlusion cause spasm of levator and the tensor muscles. This cause gag, overextended lingual flange, and finally high polished denture surface. All these causes may cause gagging for your patient. Okay, taste alteration or alter taste. This is a very common problem when you make an acrylic resin denture, because the acrylic resin is not also a thermal insulator, but it also alters the taste sensation because it covers the hard palate that contains some taste buds. We must explain for our patients that using a full coverage denture like or acrylic plate like that will alter his taste sensation for a little of time until he accommodates for the new denture position. If we use a metal base or using an overdenture, we can make an open palate denture. So we solve the problem. We may solve the problem by another solutions. Using a metal base also may have a better thermal stimulation and a better taste sensation. We may have a hidden porosity in the fitting surface of the denture. Hidden porosity will be a better place for bacterial growth, and this will cause a taste alteration also. The bad oral hygiene, if the patient can't brush his denture well and can't clean it well from the food debris, it will cause also inflammation of the mucosa and the alteration of taste sensation. So you must educate and motivate your patient about the good oral hygiene measures and instruct the patient well to do his proper oral hygiene measures after you deliver your denture. Okay, we are now talking about the problem of the T Sclattering. The T Sclattering may be occur from unfamiliarity with the new denture. If your denture is new, it is normal when your patient speak that his teeth clapping with each others or making a clattering during speech. Increase the vertical dimension of occlusion is also this is a very common sign of increased vertical dimension of occlusion because there is no sufficient interarch space that the patient can use for speak, and the teeth contact sooner, so it make a noise during speech. Cuspal interference may also a problem. Unstable denture, if the denture falls during speech, it will cause cluttering. Okay, this is a very important complaint, aesthetics. As you see here, this is not this is a complete denture aesthetics. As you see, it may be better than the patient vital tissues. Here we must mimic the patient. The aesthetics will not constricted to the teeth only, but you must also mimic the shape of the mucosa and the shape of the bony eminence, as you see here. You gain, and also not also the shade of the teeth, but also the shade of the denture base to mimic the buccal mucosa, and the if you have a partial denture, the flange color must be the same, in the same shade as the alveolar ridge color. Okay, we must properly select the shade, as we said, the shade of the teeth and the shade of the mucosa. The size of teeth, we must select also the size of the suitable size of teeth for your patient, and get his approval in the try-in stage. If you can make an ideal arrangement, or you can make a particular arrangement for your patient to restore his original smile. Facial appearance is also important. The teeth must support the lips properly and support the cheeks to give a more younger appearance for your patient. But please don't over contour your denture or setting your teeth so far labially in order to mask the wrinkles or the nasoalveolar vestibule, nasolabial vestibule, sorry. General dissatisfaction, we try to reach our patient satisfaction as much as we can. So you may face a problem of patient dissatisfaction, and this may require that you reset the case in a position that may increase your patient satisfaction for your case. Okay, here we will talk about guidelines for tooth arrangement to have a good aesthetics. If we look from frontal view, the anterior teeth must be parallel. The anterior occlusal plane here must be parallel to the interpupillary line. Inside the edge of maxillary incisors will be 2 mm below upper lip at rest. No bulging under the upper lip. Normal philtrum view. Full vermilion border of lip should be seen. The smile line of upper anterior follow the upper curve of the lower lip. Here, as we see, the anterior occlusal plane must be parallel to the interpupillary line, and the display of anterior teeth from 2 to 4 millimeters here. And in the active smile, as you see here, the smile curve will be parallel to the superior surface of the lower lip. Okay, the posterior teeth from frontal view, suitable space of buccal corridor. As we see here, if we let much space, it will give black corners here. This is a bad aesthetics. If we block it like this, it may cause cheek biting and give also bad aesthetics. If we make it normal like this, normal space like this, we give a sufficient space for bolus of food during chewing and give good aesthetics. And also give a space for the buccal mucosa and the cheek during chewing and decrease the chance that the patient can bite his buccal mucosa here. Okay, denture base shouldn't be visible in upper premolar area. Level of mandibular first premolar not superior to the angle of the mouth when the mouth is open. Posterior plane of occlusion shouldn't drop down posteriorly. It may cause sad face like this. Here we see the occlusal plane is inclined upward, and this is cause a happy face for the patient to smile. If the posterior occlusal plane dropped posteriorly like this, it will cause a sad face like in the sad smile we use on our chat. Okay, in the sagittal view, anterior teeth, we must have an everted upper lip. Here, this is the sagittal view. We must have everted upper lip like this, supported by teeth. To support of lip, 2/3 the labial surface of the anterior. In posterior teeth, upper posterior occlusal plane should be parallel to the ala tragus line. Lower posterior occlusal plane should be 2/3 height of the retromolar band. Okay, horizontal view like this. Central incisors will be placed or sat 8 to 10 millimeter anterior to the incisive papilla here. It will be 8 to 10 millimeter anterior to incisive papilla. Canines on one line here, as we see. On one line, drawn perpendicular at the midline of the incisive papilla. But the posterior teeth, lower buccal cusps or central fossa on the crest of the ridge, as we see, the central fossa here is centered onto the crest of the ridge. Here, as you see, the lab work is also very important to achieve your patient satisfaction during a try-in visit. The characterization of wax like this and give this high aesthetics for your denture to mimic the natural the natural aesthetics for your patient will lead to your patient satisfaction. You see here from different angles. Okay, finally, we are talking about problems of old denture. Problems of old denture may be due to loss of fat or overextension or overclosure. Loss of fat and overextension after time from using the denture. This continuous irritation without denture serviceability and without relining and if the patient use the denture without rest, this irritation will lead to formation of hyperplastic tissue. The hyperplastic tissue may be as a form of papillary hyperplasia in the hard palate, as a form of flabby ridge on the alveolar ridge, on the crest of the ridge, and in the form of epilas fissuratum in the vestibule also may be found. So it is very important to instruct the patient for the periodic recalls after delivery. The patient must have recall visits every 6 months after denture delivery, even when there is no complaint. just to make sure that everything is okay. Chief complaint of old denture discomfort. The patient come and complain from discomfort, discoloration of teeth or denture base, or complain also from abraded denture base or abraded teeth, artificial teeth. The overclosure problem, low vertical dimension. As we said before, if you make a high vertical dimension in your prosthesis, the patient will come faster. During the first week or the second week, it will complain. But if you make a low vertical dimension of occlusion, the patient will complain, but after a long period of time. Due to the low vertical dimension may not be also may also occur by resorption. The resorption will need to denture settling and increase freeway space between upper and lower teeth. Denture also will settle and cause irritation for the flanges, cause irritation for the soft tissue and vestibule. Also, the teeth can wear. So the vertical dimension can be decreased from resorption and from teeth abrasion or wear, and from denture settling, leading to anterior resorption and TMD problems. Several TMD problems can be made, and this patient must be treated by making a new denture or restoring the vertical dimension of his old denture. Hyperplastic tissue here, the management. We must identify the difference between hyperplasia and hypertrophy. Hypertrophy is increase the sides, increased side of cells of the mucosa. But hyperplasia or hyperplastic transformation is increased number of the mucosal cells. So the hyperplastic tissue is preferred to be removed surgically, but hypertrophy may be disappeared after you have a denture rest. So take the old denture from your patient and have a denture rest until the hypertrophy disappeared. You can use the patient old denture also for mouth preparation. You can use a tissue conditioning material inside the fitting surface of denture in order to rehabilitate the tissues for the new denture you can make for him. Also, you can remove the hyperplastic tissue, as we said, if the enlarged soft tissue not resolved by tissue rest. So this is a hyperplastic tissue, and it should be removed surgically. Low vertical dimension of occlusion. By SEER method, we can restore the vertical dimension of occlusion for the old denture. By increasing the vertical dimension by occlusal pivoting technique. Here we increase the vertical dimension in lower second premolar and lower first molar and second molar by adding acrylic resin on their occlusal surfaces. If there is any pressure areas and the high extension of the flanges due to poor resorption, you must relieve it in order to decrease the irritation. If there is low fit, do a tissue conditioning material. We use it several times because after the plasticity of the tissue conditioner also lasts for a few days, and then it becomes hard. So we use a tissue conditioning material several times and then reline the denture. If we reline the denture, if the acrylic resin is abused and contains the microorganisms or contains the bacteria, so preferred here to rebase the denture or remake the denture and make a new one. Thank you for your listening, and I wish I will meet you soon, inshallah, in another lectures. Thank you,
Thank
Dr.
you so much. Thank you so much, Dr. Mahmoud Ramadan, for this informative session. It was a very nice presentation. Meanwhile, I'll ask your permission to introduce our company to all the participants, and I request all the participants to kindly put their questions in the question and answer box. This is our organization, DentistChannel.Online, Healthy Smiles, Wealthy Lives. DentistChannel.Online is India's first digital dental media company. We did webinars and courses with more than 400 national and international